Good morning. I thank the scientific committee for this opportunity. Atrial fibrillation is the most common sustained cardiac arrhythmia worldwide in adults. The prevalence is said to be about 2 to 4%, and we expect 2 to 3-fold rise in the next years due to extended longevity. It is said to be around 600 to 699 per 100,000 population in Southeast Asia. Atrial fibrillation is more common in males, and the lifetime risk of atrial fibrillation increases with increasing risk factor burden. These are the risk factors implicated in developing atrial fibrillation. Most we have known for a while now. The ones which are more recently established are physical inactivity, alcohol consumption, obesity, and obstructive sleep apnea. Atrial fibrillation can present as death, stroke, heart failure, cognitive decline, vascular dementia, depression, impaired quality of life, and repeated hospitalization. We don't have a recent data in the Philippines. This is a bit dated, but as part of the National Health Nutrition Survey in 2008, in a survey of 3,907 ECGs of adults 20 years old and above, the prevalence of atrial fibrillation at the time was 0.2%. Note that the age group 70 years old and above, the prevalence of atrial fibrillation is 2%. In the global registry of AF-associated stroke, a hospital in Manila reported 11% atrial fibrillation stroke risk. I'll be presenting a summary of the 2020 European Society of Cardiology guidelines for atrial fibrillation, with emphasis on statements relevant to the clinician and focusing on diagnostic and therapeutic modalities available locally. Atrial fibrillation is defined as a supraventricular tachyarrhythmia with uncoordinated atrial electrical activation and consequently ineffective atrial contraction. On ECG, it appears as irregularly irregular R to R intervals and absence of distinct repeating P waves. Instead, what you see are irregular atrial activations, which you call F waves or fibrillatory waves. Clinical atrial fibrillation can either be symptomatic or asymptomatic AF that is documented by surface ECG. The minimum duration of an ECG tracing of AF required to establish the diagnosis is at least 30 seconds or an entire 12-lead ECG. AHRE or atrial high rate episodes are events fulfilling programmed or specified criteria for AHRE that are detected by CIEDs, meaning pacemakers, defibrillators, or CRT, with an atrial lead allowing automated continuous monitoring of atrial rhythm and tracing storage. Subclinical AF includes AHRE, confirmed to be AF, detected by insertable cardiac monitor or wearable monitor and confirmed by visually reviewed intracardiac electrograms or ECG recorded rhythm. It is a new Class 1B recommendation to document ECG to establish the diagnosis of atrial fibrillation and a standard 12-lead ECG recording or a single lead ECG tracing of 30 seconds or more showing heart rhythm with no discernible repeating P waves and irregular R to R intervals. This is how we electrophysiologists diagnose AHRE during interrogation or checking a patient's pacemaker or defibrillator or CRT. This is the programmer, and this is the usual signals we see in patients with AHRE. Atrial fibrillation is classified as first diagnosed, sometimes termed incident or newly documented if it wasn't diagnosed before, irrespective of its duration or the presence or severity of AF-related symptoms. Paroxysmal is that which terminates spontaneously or within intervention within 7 days of onset. Persistent is that which is continuously sustained beyond 7 days, and continuous AF of more than 12 months duration is termed long-standing persistent. Now, permanent, previously defined as failure of rhythm therapy, is that which is accepted by the patient and physician, and no further attempts to restore or maintain sinus rhythm will be undertaken. It represents a therapeutic attitude of the patient and the physician rather than an inherent pathophysiological attribute of AF, and the term should not be used in the context of rhythm control strategy with antiarrhythmic drug therapy or ablation. The guidelines recommend not to use the following terms: lone AF, valvular or non-valvular AF, and chronic AF, because these terms might be confusing in terms of therapeutic relevance. This guidelines advocates the use of the 4S AF scheme. This is a class 2AC new recommendation. The first S pertains to stroke risk, assessing whether the patient is truly at risk of stroke, of course, using the CHADS-VAS score. The second S pertains to symptom severity, using the ERA or the Modified European Heart Rhythm Association score. The third S pertains to severity of AF burden that we can determine using a Holter that details the frequency of AF paroxysms. And the last S stands for substrate severity, which usually pertains to atrial myopathy, seen as abnormality of the left atrium in cardiac imaging. The following are screening modalities for atrial fibrillation. In the Philippines, patients can probably be screened by using home BP monitors, of course, by appreciation of pulses. There are now patients with mobile single lead ECGs paired with a smartphone, smart watches. Of course, we still use Holter monitor. Sometimes we can diagnose atrial fibrillation when they are monitored in ICU or telemetry. And implantable cardiac monitors or implantable loop recorders are available in the country. One of the more popular brands of mobile single lead ECG is Cardia. Our patients purchase it abroad, although the software is not officially available locally. It can trace a single lead ECG resembling that of lead 1 by using the sensors for the left finger and the right finger. And the latest model actually features a bottom sensor, which the patient can press against the knee or the left ankle, and it's now able to trace a 6-lead ECG. Recently, the software for recording ECG in Series 4 iWatch has been made available locally, and patients can actually trace a single lead ECG resembling lead 1 by placing the watch against the left wrist and a right finger on the dial. They can save the ECGs as a PDF form and send these to their doctors or hospitals. This is actually my ECG, and it can be crisp enough to diagnose abnormal rhythm. This table shows the sensitivity and specificity of various AF screening tools. Note that this should be interpreted with caution, as the assessment of sensitivity and specificity within many studies was based on small observational cohorts. What's notable, though, is a recent meta-analysis reported that screening for AF using devices would not detect more cases than that screening with pulse palpation. Thus, we at the Philippine Heart Rhythm Society recently launched Alamin ng iyong pulso, which coaches the patients to feel their pulses and screen for possible irregularity. It is recommended to do opportunistic screening by pulse taking or ECG rhythm strip in patients 65 years old and above, and it is recommended to interrogate pacemakers and implantable cardioverter defibrillators on a regular basis to screen for AHREs. When screening for atrial fibrillation, it is recommended that the individuals undergoing screening are informed about the significance and treatment implications of detecting atrial fibrillation. A structured referral platform is organized for screen positive cases for further physician led evaluation to confirm the diagnosis of AF. And the definitive diagnosis of AF in screen positive cases is established only after the physician reviews the single lead ECG recording of at least 30 seconds or a complete 12 lead ECG confirms that it shows AFib. It's also recommended that systematic ECG screening should be considered to detect AF in individuals more than 75 years old or those at high risk of stroke. This details the diagnostic workup and follow-up in AF patients. In all AF patients, medical history should include any AF-related symptoms, AF pattern, concomitant conditions, and CHA2DS2-VASc score. A 12-lead ECG must be traced. Thyroid, kidney function, electrolytes, and full blood count must be checked, and 2D echo must be done. In select AF patients, some of the tests that can be done are Holter monitoring to check for adequacy of rate control, coronary CTA or ischemia imaging if you suspect coronary artery disease, and of course, brain imaging if you suspect stroke. A structured follow-up should be done to ensure continued optimal management. It is a Class 1C recommendation to evaluate AF-related symptoms, ideally using the modified ARIA symptom scale before and after initiation of treatment, including cardioversion. In the integrated atrial fibrillation management, it is visioned to be patient-centered with optimization of stroke prevention, symptom control, management of cardiovascular risk factors, as well as education, lifestyle modification, strategies to promote medication adherence. It's visualized to become a multidisciplinary approach with the patient in the center, ABC pathway, which can also stand for atrial fibrillation better care, is a new holistic pathway streamlined with integrated care of atrial fibrillation across all healthcare levels among different specialties. A stands for anticoagulation or to avoid stroke. B is better symptom control. And C is comorbidities or cardiovascular risk factor management. Now, this is the CHA2DS2-VASc score, which you probably all know. Note that C is any heart failure clinical diagnosis or any recently compensated heart failure, regardless of ejection fraction, that carries 1 point. Hypertension, regardless of control, even those which are treated, carries 1 point. Diabetes mellitus, even those which are controlled on medications, also carries 1 point. And the female sex or gender is considered a stroke risk modifier rather than a risk factor. One can have a maximum score of 9 in CHA2DS2-VASc. The Hasblad score, on the other hand, identifies patients who may be at risk of bleeding. Note that a lot of these factors are actually modifiable. Blood pressure can be controlled. Warfarin time to therapeutic ratio can be improved, prescription drugs can be revised, and alcohol consumption can be controlled. And the objective should be to control these risk factors to reduce bleeding. This table shows the standard doses of novel oral anticoagulants. Available locally are dabigatran, rivaroxaban, and apixaban, and they should be reduced depending on creatinine clearance, age, or concomitant use of certain medications that may affect their pharmacokinetics. Note that currently, only those with mechanical heart valves or moderate to severe mitral stenosis are recommended to exclusively receive vitamin K anticoagulation using warfarin. For the other patients, The first step should be identifying low risk patients, and these are patients with CHA2DS2-VASc score of 0 in males and 1 in females. And for those group, no antithrombotic treatment is necessary. Next step is to address any modifiable bleeding risk factors using the Has-Bled score. And if the CHA2DS2-VASc score is 1 or 2 in female, then oral anticoagulation should be considered. And if the CHA2DS2-VASc score is 2 or more or 3 or more in female, oral anticoagulation is recommended. While the randomized controlled trials of the four novel oral anticoagulants just showed non-inferiority to warfarin, meta-analysis of all four RCTs actually showed better safety profile in terms of 10% reduction in all-cause mortality, 14% reduction in major bleeds, and 52% reduction in intracranial hemorrhage. Thus, it's a class 1 recommendation to prefer NOACs over warfarin, of course, excluding patients with mechanical heart valves or moderate to severe mitral stenosis. Again, it's a class 1A recommendation to use the CHA2DS2-VAD score for stroke risk assessment, and it's a class 1 recommendation to use anticoagulation in patients with CHA2DS2-VAD score of 2 or more in men or 3 or more in women. It's a class 2A recommendation to give anticoagulants in patients with CHA2DS2-VASc score of 1 in men or 2 in women. And Has-Bled score should be used and bleeding factors modified using the It's a class 2A recommendation to give oral anticoagulants in patients with CHA2DS2-VASc score of 1 in men or 2 in women. And it's upgraded to class 1 from class 2B to use Has-Bled to identify any modifiable risk for bleeding. It is also a Class 1B recommendation to do stroke and bleeding risk assessment at periodic intervals. And in patients with AF initially at low risk of stroke, first reassessment of stroke risk should be made at 4 to 6 months. In patients who are given warfarin, a target of 2 to 3 is still recommended, with ideally checked individual time to therapeutic ratio of more than 70%. That's a class 1B recommendation. In patients with warfarin but with low time in INR therapeutic range, meaning TTRs of less than 70%, it is recommended to switch to a NOAC, ensuring good adherence and persistence with therapy. This is upgraded to class 1B from 2B. Antiplatelet therapy alone is not indicated. Estimated bleeding risk in the absence of absolute contraindications to oral anticoagulation should not in itself guide treatment decisions, and clinical pattern of AFib should not be the condition to indication of thromboprophylaxis. About patients with atrial fibrillation undergoing percutaneous coronary intervention, which usually requires dual antiplatelet therapy. The West trial, or warfarin plus dual antiplatelet of aspirin and clopidogrel versus warfarin alone, did not result to increased thrombotic events and of course resulted to less bleeding in patients given only warfarin and clopidogrel. The same result was also observed in the Redual trial, which compared the bigatran in 110 or 150 milligrams compared with dual antiplatelet therapy versus the bigatran and one PY12 inhibitor alone. It also showed lower bleeding and was non-inferior in the risk of thromboembolism. And so these are new recommendations, in atrial fibrillation patients with acute coronary syndromes undergoing uncomplicated PCI, early cessation less than a week of aspirin, and continuation of dual therapy with an oral anticoagulant and a PY12 inhibitor, preferably clopidogrel, for up to 12 months is recommended if the risk of stent thrombosis is low or if concerns about bleeding risk prevail over concerns about risk of stent thrombosis. For patients with atrial fibrillation and chronic coronary syndrome undergoing PCI, it's a new class 1 recommendation. After uncomplicated PCI, early cessation, meaning less than 1 week of aspirin and continuation of dual therapy with an oral anticoagulant of up to 6 months and clopidogrel is recommended if the risk of stent thrombosis is low and if concerns about bleeding risk prevail over concerns about risk of stent thrombosis, irrespective of the type of stent used. Shown here are therapies to prevent stroke in patients with very high risk of bleeding. On the left is the left atrial appendage occluder watchman inserted via a femoral vein access and using a transeptal puncture. And on the right is surgical ligation of the appendage done during cardiac surgery. Among the left atrial appendage occluders, it's only the Watchman which has an RCT showing non-inferiority to warfarin in preventing stroke. In my knowledge, there's only one implant of Watchman in the country, and I know that our surgeons can do cardiac ligation of the appendage. It's still a class 2B recommendation to consider left atrial appendage occlusion for stroke prevention in patients with AF and contraindications to long-term anticoagulant treatment. For example, those who had intracranial bleeding without a reversible cause. And it's also a class 2B recommendation to do surgical occlusion or occlusion of the left atrial appendage for stroke prevention in AF patients who are undergoing cardiac surgery. We now go to better symptom control. First, with rate control therapy. Now, rate control therapy can be a background therapy for all atrial fibrillation patients. It can be the first choice therapy in patients with no or minor symptoms. It can be a therapy that we choose after failure of rhythm control. It can be a therapy that we choose when risk of restoring sinus rhythm outweigh the benefits. Now, with the RACE trial, a lenient heart rate control, that of heart rate less than 110 beats per minute, can be a reasonable target for most patients. However, those with symptoms or deterioration of left ventricular function or those with CRT should aim a lower heart rate of less than 80 beats per minute. These Among the beta blockers used for rate control, only esmolol is available locally in its IV form, and all of the oral medications are available locally. In case of asthma, we prefer beta selective beta blockers, and beta blockers may be contraindicated in acute heart failure and those with history of severe bronchospasm. And for these patients, your other choice may be non-dihydropyridine calcium channel antagonists, and verapamil and diltiazem are both available in IV and oral forms locally. Note that it's contraindicated in patients with heart failure and reduced ejection fraction, and doses should be adopted in hepatic and renal impairment. Digoxin may also be used as rate controller. Amiodarone at the lower dose may also be used as a rate controller. After assessing for comorbidities, and this may be heart failure, severe COPD, or asthma, a choice of first-line treatment is either a beta blocker or a non-dihydropyridine calcium channel blocker. Of course, patients with pre-excitation should be ablated. Clinical reassessment should be done to determine adequate rate control. And if suboptimal, it can be considered to add on a second line treatment. And finally, a third tier considering pacemaker implantation or AV node ablation can be considered if heart rate control is still not optimal. Beta blockers, diltiazem or verapamil, are recommended as first choice drugs to control heart rate in AF patients with left ventricular ejection fraction of more than 40%. For patients with left ventricular ejection fraction of less than 40%, beta blockers and or digoxin are recommended to control heart rate. A combination therapy comprising of different rate controlling drugs should be considered if a single drug does not achieve the target heart rate. This is a 2A recommendation. And the target should be a resting heart rate of 110 beats per minute for lenient rate control. AV node ablation should be considered to control heart rate in patients unresponsive or intolerant to intensive rate and rhythm control, and this can be done locally, and in patients with hemodynamic instability or severely depressed left ventricular ejection fraction, intravenous amiodarone in reduced doses may be considered for acute control of heart rate. Now, rhythm control strategy is chosen to reduce AFib-related symptoms and improve the quality of life. It is therefore important that we first evaluate if the symptoms are present before choosing a rhythm control strategy. If the symptoms are present, it's also important to determine whether the symptoms are due to AFib or not. If the symptoms are related to atrial fibrillation, then it's reasonable to proceed with rhythm control. These are the factors favoring rhythm control: younger age, first AFib episode, tachycardia-mediated cardiomyopathy, normal to moderately increased left atrial size, no or few comorbidities, difficult rate control, atrial fibrillation precipitated by a temporary event, or it can be simply a patient. If the non-favorable factors are prevailing, then we anticipate that the rhythm control strategy might be difficult. Then it's important to reassess if there are risk factors for atrial fibrillation that can still be modified. It may be considered to refer to an electrophysiologist. If the favorable factors are prevailing, then a rhythm control strategy, either using anti-arrhythmic drugs or pulmonary vein isolation via catheter ablation, can be selected. It's a class 1A recommendation to choose a rhythm control therapy for symptom control and improvement of quality of life. Flecainide is available locally in its oral form, and the initial dose for cardioversion is 200 to 300 milligrams. It should not be used though in patients with ischemic heart disease and or any significant structural heart disease. It may induce hypotension or atrial flutter with fast AV node conduction. So sometimes we use it alongside a beta blocker. And for that reason, we do not use it for pharmacologic conversion of atrial flutter. Amiodarone is available in its IV and oral form. Note that it may cause phlebitis, so we avoid administering it in more than 24 hours. It may cause hypotension, bradycardia, AV block, or QT prolongation. So ideally, patients should be monitored on initiation. And it's only used if no other options are present in patients with hypothyroidism because, as we know, it has risk of thyrotoxicosis. After successful cardioversion of atrial fibrillation, the following should be done: early recognition of AFib recurrence, evaluation of efficacy of rhythm control by symptom assessment, monitoring of risk of proarrhythmia by the antiarrhythmic drugs of choice, evaluation of balance between symptoms and side effects of therapy, evaluation of AF-related comorbidities and antiarrhythmic drug-related side effects, and optimization of conditions for maintenance of sinus rhythm, including blood pressure control, heart failure treatment, increasing cardiorespiratory fitness, and other measures. These are all class 1 recommendations for pharmacologic cardioversion in patients with no recent acute coronary syndrome or severe heart failure. Flecainide is recommended along with the propafenone and the vernaculant, which are not available locally. Intravenous amiodarone is recommended for cardioversion of atrial fibrillation in patients with heart failure or structural heart disease. Cardioversion of atrial fibrillation, whether electrical or pharmacologic with medications, is recommended in symptomatic patients with persistent AFib as part of rhythm control therapy. And pharmacologic cardioversion is AFib is indicated only in hemodynamically stable patient after consideration of the thromboembolic risk. There are new recommendations favoring catheter ablation in the rhythm control strategy due to recent published trials. One is Cabana, which enrolled 2,204 patients with symptomatic atrial fibrillation, 42% with paroxysmal AFib, and 57% with persistent atrial fibrillation. This graph shows the composite endpoint of death and hospitalization in patients who had drug therapy in blue and catheter ablation in orange, showing trend of less event rates in patients who underwent catheter ablation. However, this is not statistically significant. Looking at this graph, which shows the freedom from recurrence of atrial fibrillation, there is significantly less patients who are free from AFib after 48 months in those who receive drug therapy compared to catheter ablation. Castle trial or catheter ablation for atrial fibrillation with heart failure randomly assigned patients with symptomatic paroxysmal or persistent atrial fibrillation, this time with heart failure, NYHA classes 2 to 4, and a left ventricular ejection fraction of 35% or less, and implanted defibrillator. Note that this study showed less worsening of heart failure in patients who underwent ablation versus medical therapy, less death from any cause in patients with ablation compared with those who just received medical therapy, and less hospitalization for worsening heart failure in patients who underwent ablation compared to those who received medical therapy. Isolation of pulmonary vein triggers is achieved either via point-by-point ablation using radiofrequency along the pulmonary vein antra or by inflating a cryoballoon that completely hugs the pulmonary vein antra. No technique has been established to be better than the other. However, radiofrequency ablation has been around for a longer time, and this also allows ablation of other substrate, including atrial flutter. If it's just paroxysmal atrial fibrillation, there can be a more complete isolation of pulmonary vein triggers when you use cryoballoon. On the top is the electrophysiology laboratory setup with the 3D imaging. This is a 3D reconstruction of the pulmonary veins, which facilitates point-by-point radiofrequency ablation. On the bottom is electrophysiology laboratory setup using a cryoballoon. And this is the cryoballoon completely occluding the pulmonary vein antra. These are fluoroscopy images during a pulmonary vein venogram showing the cryoballoon in the left superior pulmonary vein and in the right superior pulmonary vein. And these are electrogram signals showing absence of pulmonary vein potentials, as well as block between the left atrium and pulmonary veins after successful isolation by cryoablation. There are currently only 2 hospitals who can do cryoablation for atrial fibrillation locally, and this table shows our early local experience of patients who underwent cryoablation, all with paroxysmal atrial fibrillation. As of the moment, all in sinus rhythm with no antiarrhythmic drugs between 16 to 19 months now. This algorithm details an indication for catheter ablation in patients with symptomatic atrial fibrillation, whether they have paroxysmal or persistent atrial fibrillation with major risk factor for atrial fibrillation recurrence. It can be just the patient's preference. It can be after a failed drug therapy with varying recommendations. It is first recommended to take into consideration the procedural risks and major risk factors for AFib recurrence following atrial fibrillation ablation, and to discuss this with patient. Repeated pulmonary vein isolation procedures or catheter ablations may be considered in patients with AFib recurrence, provided that the patient's symptoms were improved after the initial pulmonary vein isolation. It's a class 1A recommendation to do catheter ablation after a failure of drug therapy, whether it's paroxysmal AFib or persistent AFib, with or without major risk factors for AFib recurrence. It's reasonable to select atrial fibrillation catheter ablation as a rhythm control strategy after one failed or intolerant to beta blocker treatment to improve symptoms of AF recurrences in patients with paroxysmal and persistent atrial fibrillation. It can also be considered as a first-line therapy for patients with paroxysmal AFib episodes. This is a new 2AD recommendation, and it can be considered as a first-line therapy for patients with persistent atrial fibrillation without any major risk factor for AFib recurrence. This is a class 2B-C recommendation. It can be considered as a first-line therapy, catheter ablation, to reverse left ventricular dysfunction in atrial fibrillation patients when tachycardia-induced cardiomyopathy is highly probable, independent of their symptom status. This is a 1B recommendation. Finally, several atrial fibrillation risk factors may contribute to the development of left atrium substrates and thus affect the outcome of AF catheter ablation, predisposing to higher recurrence rate. And so aggressive control of these modifiable risk factors may reduce recurrence rate. It's recommended to identify and manage risk factors and concomitant diseases as an integral part of treatment in AF patients. It's a recommendation to modify any unhealthy lifestyle and target therapy of intercurrent condition to reduce AF burden and symptom severity. It is recommended to do opportunistic screening for AF in hypertensive patients, and it is recommended to pay attention to good blood pressure control to reduce AFib recurrences and also to reduce the risk of stroke and bleeding. It's now a new 2A recommendation that in obese patients with atrial fibrillation, weight loss together with management of other risk factors should be considered to reduce AF incidence, AF progression, AF recurrences, and symptoms. Thank you.
Dr. Segundo. That was a very extensive review on the 2020 ESC guidelines and in AF in general. So there are actually several questions that were posted, Luigi, on the Q&A
All right.
box. Let's go to the first one. the question would be, what should we do if the Chad VASC score and Hasbled are equivocal?
Yeah, okay. There's probably multiple interpretations of that question, but by equivocal Chad's VASC, what I can think of is a Chad's VASC score of 1 in males
One.
and a 2 in female. Remember, female gender is now a modifier, not really just a score. So the guidelines clearly state recommending 2A level of recommendation, anticoagulation, no longer antiplatelets. Before it was antiplatelets, right? So I would anticoagulate. But if the interpretation is the Hasbled is high as well, remember that the Hasbled score, they're not set in stone. You can lower the Hasbled score by modifying whatever score is high, for example, hypertension or alcohol consumption. But if after modifying risk factors, the Hasbled score is high, we can actually do non-pharmacologic measures such as occluding the left atrial appendage. We have Watchman that's available locally. It's not widely used, but we can do it here. Surgical application is also done in the setting of cardiac surgery. That note that that requires lifelong antiplatelet though, but it can eliminate use of anticoagulation after about 1 month.
Thank you. Another question from Dr. Ong. In the era of these new gadgets that we can use to detect rhythm abnormalities regarding the Cardia app, does it detect myocardial infarction or just it detects the rhythm like AF for patients who use it as a tool because they are hesitant to go out to get a 24-hour Holter monitor?
Good question, Eric. All of these gadgets will have disclaimers that it will not diagnose heart attack for patient's perspective. Remember that it's just a rhythm strip. So all it detects is rhythm. So I would say it's similar to Holter monitor. Even the Cardia app that records 6-lead ECG, remember it's just similar to those leads. So it's not a complete 12-lead ECG. So it cannot diagnose myocardial infarction, just abnormal rhythm, including atrial fibrillation.
Okay, thank you. There are two questions from Dr. Amikan. Based on your experience and also being online with the guidelines, first question would be, do you have a preference for a beta blocker that is best probably for heart rate control with those with an EF of more than 40%, more than 40%? So preserved EF.
No preference. If it's just purely rate control, there's no mention of a preferred beta blocker, but you have to consider concomitant conditions. Or for example, your patient will have a young male patient. The best evidence reducing risk of ED is nebivolol. If you need to also control blood pressure, then you might consider a higher dose. If there's heart failure, there are certain beta blockers that we consider for heart failure more than the others. But by rate control alone, there's no one beta blocker that's recommended.
Or better than another.
Or better than another, yes, correct.
Second question would be, do you do a more conservative approach for patients that are younger, who are less than 40 or more than 50 as a comparison?
Okay. By conservative approach, I'm assuming this is a rate control strategy more than the rhythm control strategy, right, Dr. Amikan? Actually, no, but you have to consider a lot of things, not just age, concomitant risk factors as well. If you go by a firm trial, which says that there's no significant difference between rate and rhythm control, and no trial has yet proven that one is better than the other, those enroll patients who are mostly in 65 years old and above range. So for the younger patients, I actually tend to be more aggressive. Why? Because we don't want them in lifelong antiarrhythmics, for example. These patients might still be at risk of tachycardia-induced cardiomyopathy or coronary artery disease that might complicate if we just be complicated if we just settle for rate control. Also because the outcomes of catheter ablation are actually much better if you do it in patients who are young and with smaller left atrial size. So I tend to be more aggressive actually with younger patients.
Okay, another fast question, Luigi. How long do you maintain anticoagulation after successful spontaneous cardioversion?
the CHA2DS2-VAS score should be the determining factor. But if the CHA2DS2-VAS score is 0, then after cardioversion, you still have to maintain them an anticoagulation for 4 weeks because of possible atrial myopathy, and you still have risk of clot formation there.
Okay, another one. Best antiarrhythmic agent for acute AF secondary to thyrotoxicosis, aside from a beta blocker.
Secondary, oh, well, you're just limited with, in the Philippines, flecainide and amiodarone. So if there's thyrotoxicosis, then you will prefer flecainide. Although by efficacy, amiodarone is actually more superior. It's just this, the safety profile is not good. So maybe flecainide.
AF is a very
Or
interesting topic.
cardioversion, electrical cardioversion. Yeah.
Another question. Siguro we can entertain one more. When would you consider
Sure.
pacemaker and AV nodal ablation in AF?
If you look at the tier, it's actually in the last tier because we don't want patients to be dependent on a pacemaker. So I'll probably consider that in patients already with sinus node dysfunction or intermittent AV block. Permanent pacemaker will also have its possible complications long term, like cardiomyopathy associated with RV pacing. So I will only consider that in patients already with indication for a device, a CRT or a pacemaker.
Okay, maybe just entertain one last question. How are you going to
Sure.
handle all these cases coming out from the use of the smart watches? And how do
Yeah.
you pare down what is significant or not?
That's a very good question, Samuel Versosa. So actually, if you look at the guidelines, it now advocates a multidisciplinary approach. I'm actually thinking of setting up like a call center. It's not possible for us to receive all of these ECGs. I'm imagining all of your Viber groups are busy now, right? So maybe this early, if you want to consider that, consider a receiving area or a call center in the hospital or in the clinic, which will offer an immediate feedback to the patient. That just an assurance that it's not dangerous and that they need to see you the next clinic hour. Or if the arrhythmia is dangerous, then maybe they need to see to go to the emergency room. No, not really personally receiving all of them.
Thank you so much, Dr. Segundo.